Hello, everyone. This is the presentation associated with paper number 530 for EMBS 2020 conference. I would like to start by thanking the IEEE EMBS and the Canadian Bioengineering Societies for successfully organizing this conference despite the ongoing pandemic. My name is Sanjay Kharche, and I work as a research scientist and applied mathematician in Lawson Health Research Institute and Western University in Canada. I lead the computational medicine laboratory, and we primarily develop scientific software platforms called PM3. In this talk, I will present a simple 2D model of the human ventricle. I will take an overview of the future outlook. I will also take this opportunity to make an announcement. The clinical motivation is as follows, is that most modern clinical treatments, and in my case, dialysis, remains to be personalized. The suboptimal personalization does lead to a heterogeneous response of patients for the same treatment. Shown are two sets of ECGs recorded before and after dialysis, while the top set of ECGs show that the dose of dialysis benefited patient number 2. It had a serious side effect on patient number 1, whose ECG recordings are shown in the bottom panel. And so the purpose of the computational models is to rapidly quantify the disease, its mechanisms. As a systems biology approach, it will integrate, the computer models will integrate known mechanisms. Importantly, it will be a cost-effective manner of testing therapy prior to experimental and clinical investigations. Specifically for this study, the hypothesis emerged from our recent CT blood flow perfusion imaging study, where it was seen that the patient's myocardial blood flow became more heterogeneous after dialysis. And therefore, if we assume that an increase in blood flow heterogeneity also leads to an increased heterogeneity in terms of electrical conduction, we would like to sort of illustrate how this increased heterogeneity may lead to arrhythmia. And so for the purpose of this illustration, I constructed a simple two-dimensional heterogeneous model of the human ventricle, which consisted of a biophysically detailed cell model of the ventricular cardiomyocyte, as shown on the left-hand side panel. The cell model is sensitive to both hyperkalemia as well as ischemic stress, and ischemia, which is presumed to be induced by dialysis, shortens the action potential duration. Ischemic zones, as shown in the middle panel, were constructed informed by our imaging data. And the ischemic zones, the 4 millimeter wide ischemic zones, consisted of border and central regions. Within the ischemic zones, hyperkalemia was implemented, as was implemented a slowing of the electrical propagation and a reduced availability of ATP, thus increasing the ATP-sensitive potassium channel significantly. A predefined number of such ischemic zones were then distributed within a large 2D sheet, as shown on the right-hand side of the slide, to represent the underlying structural heterogeneity that might affect the electrical propagation. Proarrhythmia was essentially quantified by studying an induced spiral wave and its dynamics over the course of 10 seconds. And the results are shown in this brief animation, where On the left-hand side, the 2D sheet includes a small number of ischemic zones, 1 specifically, and on the right-hand side, it includes a large number of ischemic zones, 20 specifically. The black circles show the spiral wave tips, and what can be seen is that as the number of ischemic zones or heterogeneity increased, the number of micro re-entrant circuits represented by the increase of the black circles increased. These micro-entrant circuits were short-lived. However, they did promote higher pacing rates, especially in the border zones. The ischemic zones, due to their hyperkalemia, also promoted ectopic behavior. In addition to the biophysical simulation, the code was, or the reaction diffusion solver was developed during this study. And as can be seen in the diagram, all components of the solver are parallel, they're efficient, and that includes the file input-output, which is strictly parallel. A significant amount of time was spent in setting up the implicit solver's systems matrices, and efforts continue towards optimizing this, this computational load. And having worked with the two-dimensional case, now it has been extended to a three-dimensional slab, where the heterogeneity now is distributed using Gaussian processes in the expectation that such a distribution more better represents the heterogeneity observed in our imaging data. And it can be appreciated that an increased heterogeneity, as shown in the middle panel, ECGs at physiological temperatures, an increased heterogeneity promotes a short QT interval, a shorter QT interval. It also reduces the T wave amplitude, reflecting the increased ischemic stress. In addition to quantifying the effects of underlying heterogeneity on ECG at physiological temperatures, the model is capable of providing some insights into the mechanism of a novel therapy called therapeutic hypothermia, cooling of the heart. This is a clinical trial. This is a nationwide clinical trial ongoing with our clinical partners. And it can be seen in the bottom panel that the QT interval is somewhat corrected due to the cooling, as well as the T wave amplitude is somewhat rectified due to the cooling. The cooling was at 4 Celsius in this model. And so the summary is that, having worked with a simple 2D model, we have now extended our study into three-dimensional cases. What I have not shown here is that there is a patient-specific, realistic whole heart simulation study ongoing. Of course, heterogeneity does augment arrhythmia risk, as has been shown by multiple previous simulation studies. However, our work is now moving towards multi-physics investigations, where we would like to consider the effects of neurons, the effects of blood flow, the effects of mechanoelectric feedback on the electrical activity, as well as there potentially is feedback from the electrical activity to all these other processes. The models are now capable of generating evidence for our clinical trials, may permit patient classification, and are capable of testing therapy effectiveness. A brief announcement is that I'm now inviting contributions to a special issue in Frontiers Journal with focus on vascular disease, but should have components of multi-scale and multi-physics pathophysiological mechanisms. Contributions of reviews as well as original contributions are invited from the modeling, clinical, and experimental communities. Finally, I would like to acknowledge support from Compute Canada, Canary, and CERT for funding, as well as support from our home institutions, Lawson Health Research Institute and Western University. Finally, I thank you for your interest.